Good afternoon and welcome to OC Talk, the show dedicated to helping home health and hospice providers keep up to date on the documentation, diagnosis coding, OASIS, and HOPE assessment data collection issues that matter the most in home health and hospice. OC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're talking about the OASIS M1800 functional items versus the GG0130 self-care items. And now I'd like to introduce our industry guests for this episode. We have OC Board Secretary Apryl Swafford, QA Manager with SimiTree Healthcare with us on the call today. And we also have OC Advisory Board Vice Chair Nanette Minton, Senior Clinical Coding Manager with Mac Legacy on the call today. Nanette and Apryl, thanks so much for joining us today. Let's go ahead and get the discussion started. Listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane. We have a lot to get through today, so if you do have a question for our speakers, go ahead and ask it in the chat pane and we will follow up with you with answers offline. All right, and I'll hand it over to Apryl and Nanette.
Hello, everyone. Thanks for joining us today. Hang on a second, Joe. I lost my screen. There it is. Thanks for joining us today for the discussion. Now, what we see is there's still a lot of confusion sometimes between the guidance on the GG items and the guidance on the M1800 items and how those compare and contrast. So that's why we thought this would be a good topic to cover in an OC talk. So just basics of guidance, just the down and dirty is what we're going to go over today. So on our M1800s, we always have to look at what is the safest option for our patients. Same thing on the GG items. We're still looking at what is the safest option for the patient. Both of them look at day of assessment, and day of assessment is the time that the clinician's in the home plus the prior 24 hours. If the patient status varies on the day of assessment, we will report what is true greater than 50% of the time under consideration, unless the item guidance specifies something different, and that will always apply. You're going to have your general guidelines, and then you'll always know that if your item gives you different directions from the basic guidelines that you have, then that's what you're going to follow. In our M1800s, as you know, if you've been doing this any length of time, there are different items that talk about the use of devices, whether it's a one-handed device, a two-handed device, bedside commode, different things. On our GG items, we're not worried about assistive devices. What we're looking at is how much caregiver assistance does that patient need, with or without a device, doesn't matter. Now, one thing I don't want us to get confused about when I say day of assessment is how we're answering these, is we still have the use of our 5-day window based on the collaboration rule. So if I go out on Monday and my therapist goes out on Wednesday, that therapist is going to assess how that patient can do these M1800s and the GG items based on their day of assessment, which again is going to be 2 days past yours, but you can still use what they gather if you feel like after talking with them, that is a better response to the item. So I don't want to confuse you when I say just a day of assessment, because we still have that 5-day window that we can use to collaborate with other people involved in the care, other disciplines involved, and make those changes. Okay, Jan? So let's talk about some basic conventions for the M1800 items. And all this information, y'all, came directly out of the OASIS E1 guidance manual. The patient's ability may change as their condition improves or declines, as medical restrictions are imposed or lifted, or as the environment is modified. The clinician, again, we've already said, we're looking at what they can do on the day of assessment, which is the time in the home and the prior 24 hours. If their ability varies, we're going to look at what they can do greater than 50% of the time. We cannot assess what a patient can do with equipment that is not in the home. Remember that. We want to consider patient's safe ability to get where the task is being performed when we're looking at M1800, if that's applicable. In a multitask item, we're going to report what is true for the patient in the majority of the included tasks. Next, we're going to look at conventions for the GG self-care and mobility items. We're going over the self-care items today, but these are going to apply to the GG0130 mobility items as well. We know, again, the patient's ability may change as the condition improves or decline, restrictions are lifted or imposed, or the environment's modified. Day of assessment is what we're going to look at on these items as well. What they're able to do 50% of the time. Code based on the type and amount of assistance required to perform the activity safely. Remember, none of these, and I didn't put it on the M1800, none of these are looking at the patient's willingness to do this. They're looking at their ability to do it. Also, this is not dependent on the availability of the caregiver. What we're looking at is for this patient to perform a task safely, how much caregiver assistance do they need? It doesn't say how much assistance do they need from that caregiver that they have right now. We're looking at overall, if they have a caregiver, assuming they're going to get a caregiver, how much assistance would they need from that person? Again, they don't have to be available now, but we still want to answer it based on that, what we infer on all the information that we have. If the patient only completes a portion of the activity and does not complete the entire activity during the assessment time frame, we're going to use our clinical judgment to determine if the situation allows the clinician to adequately assess the patient's ability to complete the entire activity. So they get started and for whatever reason they can't finish the task. I don't know, maybe somebody comes in, you know, all sorts of stuff come up, but they don't finish it. So the clinician would have to use their clinical judgment to say, hey, if they had been able to complete this task, how would they have done it? A lot of times if they're not able to complete it, it's because physically or mentally they're not able to complete it. So, you know, it may not be that they could have completed the entire task. I don't know. It just depends on the situation, and you have to look at the whole chart holistically to decide what that response would be.
Apryl, Apryl and I are gonna switch off here as we talk through each of these, the GG0130 items, and a little bit more about that self-care and provide some scenarios to you. So for grooming itself, when you're looking at the M1800, this item is really only looking at those 5 specific grooming tasks: washing face and hands, hair care, shaving or makeup, teeth and denture care, fingernail care. And for the M1800s, more weight is going to be given to the tasks performed more often. Now, when you get over to the GG items, GG0130B, oral hygiene, remember those GG items are really looking at things more granular. It's going to focus on the ability to use suitable items to clean the teeth. It applies both to the natural teeth and or dentures. And then denture care includes removing, inserting dentures, and then soaking and rinsing. So if the patient has no teeth or dentures, and the documentation indicates that the patient is edentulous, you're going to look at how much helper assistance is needed to clean the patient's gums. So that's how we would look at that one.
All right, let's look at a scenario. The patient was admitted to home health after a left hemorrhagic CVA with sequela, including right arm weakness and dysarthria. She requires a walker and assist times 1 person to safely ambulate to the bathroom. She is right hand dominant, so someone must put the toothpaste on her toothbrush, and then she is able to brush her teeth using her left hand. She can perform hair care to include brushing her hair and can wash her face once supplies are handed to her. She does not routinely wear makeup and has gel nails which are managed by a nearby salon. How would you respond to M1800 and GG0130B? So again, where M1800 is looking at 5 specific items, GG0130B is only looking at oral care. So it's pretty easy on those to know that our guidance is going to be different just by virtue of the items that we're looking at. All right, Jen, if you'll hit, yup, it's going to give us our answer. So M1800, 2. Why is she 2? Because somebody's got to put the toothpaste on for her. So, you know, she's also got to have some assistance to get to the bathroom. So that tells me she has to have somebody to assist. When I look at GG0130B, however, I am a very keep it simple, stupid person. When I look at my GG items, I look at myself as I'm with that patient in a bubble. And whatever we need to complete that task is in the bubble with us. So I'm not having to worry about how they got there, all that kind of stuff that I have to look at with M1800. I'm in this bubble with this patient, and we have what we need to do this right here. So when our scenario, all she needed was somebody to put the toothpaste on her toothbrush and then lay all her stuff out for her. So in that situation, I would code her a 5 on GG0130B.
Okay, awesome. Now let's look at a scenario regarding some upper body dressing. So when you look at M1810 upper body dressing, we're looking at assessing the ability to obtain, put on, and remove upper body dressing items. Now, remember, you're going to think about what is routinely worn. And this includes applying upper extremity prosthesis, cervical collars, arm slings, and upper body orthotic or other supportive devices. But again, more granular, it's the GG0130F, the upper body dressing, is the ability to dress or undress above the waist, again, looking at what is routinely worn. And then consider the following as upper body dressing. So, you know, do they have some type of thoracic, lumbar, sacral orthotic device, an abdominal binder or back brace, a stump or sock shrinker, upper body support device, neck support, hand, arm, prosthetic orthotic. So there's a lot to consider with that one.
These are a little closer together than what some of the others may be as far as guidance, but never forget when I'm looking at M1810, I have to consider the patient's ability to get to where those supplies are if that's part of the scenario for that patient. Patient admitted to home care with a new pacemaker due to sick sinus syndrome. She's been instructed to follow post-pacemaker safety measures, including wearing an arm sling until she returns for follow-up appointment and avoiding raising her arm above her head, which can dislodge those pacer wires until they've had time to go through that Halen phase and get good adherence. She states she has trouble putting the sling on, but once her daughter helps her get it on and adjusted, she doesn't mind using it. She reports needing assistance with getting her affected arm through her shirt and bra, but is otherwise independent with upper body dressing. She verbalizes understanding of all safety instructions regarding her pacemaker. How would you respond to M1810 and GG0130F? Again, this one was pretty easy. She needed some assistance to get those things done, so she would be a 2 as far as M1810. Now, she's an independent with what sounds like the majority of that upper body dressing. She needs somebody to help with that sling. She just needs help getting her arm through her bra and her shirt, and then she can do everything else. In my world, I would code that as a 3. Now, there may be some discussion there that's more a 4. And what I always tell people, if I answer OASIS item, I'm looking at the documentation. So if somebody comes back to me and says, April, why did you answer GG0130F that way? I can point out this, this, and this. And sometimes, as we know in OASIS, there's some gray area on those.
Awesome. Okay, Thanks, April. I hope this has been helpful to everybody. These are, it's not always black and white, as April said. There's always some degree of gray. And so we want to try to help clarify some of this for you. So let's look at the lower body dressing. So M1820 says that we need to assess the ability, again, to obtain. So it's, how you're going to get the clothes, getting back to and from is what we look at on the M1800s. And we're going to obtain, put on, and remove lower body clothing. This also includes lower body prosthetics, orthotics, or other supportive devices that are considered part of that lower body dressing if ordered. And this applies even if the patient is not using or using inconsistently, but if they're ordered and they're supposed to be, then that is considered. Again, looking at what is routinely worn. So GG0130G, lower body dressing, is that ability to dress and undress below the waist, what is routine. And then you want to think about, do they have a knee brace, elastic bandage, stump, sock shrinker above the knee or below the knee, limb prosthesis. And then when you look at the lower body dressing, and we're thinking about GG0130H, thinking about that footwear. Jan, if you want to advance one slide, please. Perfect. It's the ability to put on and take off socks, shoes, or other footwear, looking at what is routinely worn, and then consider the following as footwear: the ankle foot orthosis, elastic bandages, foot orthotic, orthopedic walking boots, compression stockings. And again, consider items that are covered, that cover all or part of the foot, even if it extends up the leg as footwear. And again, with M1820 as well, footwear is considered part of the lower body.
Before I read this scenario, let me point out, I failed to get it on the slide, that when we're talking about any sort of prosthetic, orthotic, the upper arm sling that we talked about earlier, the things that we're going to talk about in this scenario, if those are ordered by the provider for the patient to use, we are going to assess their ability to perform those, whatever task needs to be done to apply those things, even if they're not compliant or not using it all the time. If it's ordered, we're going to assess the ability. All right, let's do our lower body. 74-year-old male was a referral from the community with a diagnosis of Alzheimer's dementia. He lives with his wife, grown son, and a daughter-in-law, and they are all active and supported in his care. Patient is unable to focus on answering any questions and returning demonstration, so the therapist questions the family on his ability to dress his lower body. The family states if his clothes are handed to him, he's able to put on his pants, belt, socks, and shoes, but does require cues to maintain safety during the process. The wife reports he had polio as a child and has worn a brace to his right foot and leg since he was 10 years old. She reports someone has to help him with the brace as it requires a wrap to be applied to the foot and lower leg prior to donning the brace, and he can no longer apply the wrap. Once the wrap is placed, the patient can put the brace on, but needs assistance with getting it locked into place. How would you code M1820 and GG0130 G and H? M1820, well, he has to have assistance, even if it's Q, and remember, that's still assistance, so that's going to be a 2. When we look at his lower body dressing, they say that he can do it with some cueing if they hand him to him. So I'm going with a 4 on that, not just set up, because he has to have that cueing. So 4 on my lower body dressing. As far as my footwear, one more, Jan. I'm going to put substantial or max assist because he's not totally dependent. He can at least put it on. What he can't do is put that wrap on and then fasten it up. So somebody else is completing greater than 50% of that task for him to put that brace on. So I'm going to mark GG0130H as 2, substantial or max assist.
Okay, perfect. Let's talk about bathing. So M1830 bathing, the ability to safely bathe their entire body, Now, this excludes washing the face and hands and shampooing the hair. It includes transferring into and out of the tub and shower. And there's several options of where the bath may occur. So you have to consider those in answering this question. And you cannot assess how the patient would perform with equipment they do not have. So again, as April said, we cannot assess something that the patient does not physically have there. Now, as far as GG0130E bathing, the ability to wash, rinse, and dry the face is what is considered the upper and lower body, the perineal area, and feet. So this excludes washing, rinsing, or drying the back or the hair, and it excludes transferring in and out of the tub or shower, and there's no consideration for where the bathing occurs. So again, April gave us a great thought process as I'm in my bubble, and can I perform this specific activity?
Your agency has admitted a 69-year-old female with severe bilateral shoulder osteoarthritis who will require nursing and OT for pain assessment and management. Patient's got a MAC-10 score of 9 out of 10, so she's a high fall risk. Ongoing pain level of 3 to 4 in her bilateral shoulders, and due to her emphysema, she gets dipsnick with moderate exertion. The OT documents the patient's got a walk-in shower with a handheld shower head along with a bath bench and grab bars. The caregiver reports they usually use a wheelchair to the bathroom door, where the patient will leave it and then use her walker to get to the shower. The caregiver then assists the patient onto the bath bench and has all of her supplies within reach. The caregiver is able to leave for short intervals while the patient safely completes her shower. How would you respond to M1830 and GG0130E? So if I'm looking at M1830 bathing, she has to have some assistance to get in and out of the shower, right? It says once she has her supplies in reach, she can do the shower. The important part to when you're looking at this, and I'm answering M1830, the difference in 2 and 3 is that in this scenario, that caregiver can walk out of that bathroom and leave that patient for short intervals. If they could not and had to stay there continuous, it would be a 3 versus a 2, but because she can leave her for a little bit, it's going to be a 2. GG0130E, again, I don't care how she got to the shower, how she got in the shower. What I'm looking at is their ability to bathe themselves, including washing, rinsing, and drying, and excluding the things that they talk about, does not include transferring in and out of the tub or shower. So in this instance, all we had to do was get her set up, right? We got her supplies within reach and she could do it from there. So I answered that one as a 5.
All right, so we're gonna go over toileting hygiene and then eating, and then move on. So M1845 on toileting hygiene, we're looking at the ability to maintain or to manage hygiene and clothing when toileting. Now for M1845, this includes cleaning or wiping that area, perineal and or the stoma as well, plus the ability of pulling those clothes up or down. Now, it does not assess the ability to manage any ostomy supplies or equipment, but the ostomy itself. This would also apply to perineal care if the patient had a urinary catheter, but not managing that equipment. There's no regulation that the patient must void or defecate to assess the ability to complete this task. Obviously, so that's going to be, again, looking at what is happening, as well as any assessments within that 5-day window and collaboration. So as far as GG0130C, toileting hygiene, it's the ability to perform perineal hygiene, adjust clothing before and after voiding or bowel movement. If managing an ostomy, it includes only cleaning the stoma, not managing the supplies. And again, we don't have to actually see the patient complete this task to assess the ability. And this would also apply to perineal care if the patient had a catheter as well for this one, but again, not managing those equipment.
And like Nanette said, if we're looking at a patient with a Foley catheter, or we're looking at a patient with some sort of ostomy, we're not looking at their ability to manage the equipment itself. What we're looking at is, can they perform peri-care around that Foley catheter? If somebody else takes off the wafer, the bag, whatever it is, and can the patient clean that stoma at that point? That's what we're looking at. So don't, and it's hard sometimes to separate those tasks, especially if you've been a clinician and you've been in the field and you've done those things. But just remember, we're looking at their ability not to manage the equipment, but to provide the care that's needed for that. Patient admitted to home care after bilateral knee replacements due to severe osteoarthritis. She requires assist times one person to get safely to the bathroom. She requires assistance to get on and off the toilet. Additionally, due to episodes of vertigo, she requires someone to support her upper body while using a gay belt while she stands holding on to her walker after toileting. Another person is required to assist with wiping her after toileting and pulling up her underwear and pants. So how am I going to respond to M1845 and GG0130C? Well, because she needs assistance, M1845, we're going to put that as a 2, right? She needs some assistance to get to the bathroom. She needs some assistance to hold her up. She needs somebody to help wipe her. You could argue that she was dependent in this. It would just depend on, how you looked at the documentation. And if you could argue that point based on what you know in this situation, I don't think anybody would say, hey, you're totally off base. So I would mark her as a 2. But again, you could argue it as a 3. Now, when I look at GG0130C, toilet and hygiene, I marked her as dependent. And the reason that I marked her as dependent, if anybody knows the guidance on this, on these items, she requires 2 people to complete this task right here. Now, she just needs 1 to get in there. But when she stands up, she's got to have that support, and she's got to have that second person to wipe her. So if a task requires 2 people, then the patient is considered dependent for the GG0130 and GG0170 items.
Okay, great. Thanks, April. Good info for sure. Okay, eating. So M1870, we're looking at the ability, again, assess the ability to safely feed themselves, including eating, chewing, and swallowing. Now, this does not assess food preparation or transportation of the food to the table or other area. This includes both options for oral and enteral nutrition. And there's also an option included for IV nutrition if there's no oral or enteral intake. Now, looking at the GG0130A eating item, it's the ability to use suitable utensils to bring the food or liquid to the mouth and swallow. That's it. It doesn't assess prep of the food, transporting to the table. If the patient swallows safely, and then we're really excluding that swallowing consideration for here. We're just, can they actually bring the food or liquid to the mouth and swallow, not really looking at the safety consideration for swallowing. If you've got both oral and enteral or parenteral nutrition, you're going to code based on the assistance required for oral intake only. And then inter or parenteral nutrition is not considered for this GG item.
All right, during our PT starter care visit, the therapist has the patient demonstrate how he completes eating activities. The caregiver provides the patient with small squares of sandwiches, as well as banana and cut up watermelon and cantaloupe. Patient is provided with a spoon and a fork, but he uses his hands to bring the food to his mouth, which the caregiver reports is normal for him. Patient can bring food to his mouth, chew and swallow without any signs of aspiration. Additionally, the family opted to have a G-tube placed as the patient's oral intake has decreased and he's been losing weight. So in addition to his oral intake, he also gets 4 cans of Ensure or Boost daily. How would you respond to M1870 and GG0130A? Excuse me. And GG8, I mean, M1870 is pretty easy. He's got oral intake, he doesn't have any trouble swallowing, and he also has that enteral nutrition. So he would be a 3 in this case. When I'm looking at my GG0130A, however, I don't have to make any consideration as far as what he's getting via G2, because we're not looking at that on our GG0130A. We're only looking at what he's taking in orally. And in this instance, once they give him the food, even though they give him utensils and he doesn't use them, he can still be considered just needing setup or cleanup assistance, because eating with his hands is fine as far as the guidance for this item. So in this instance, I'll make him a 5 for GG0130A.
Thanks so much, Nanette and April. That was a great run through. Those scenarios were really helpful. And now we're moving on to our scenario spotlight for this call.
Okay, great. Well, I am going to cover the coding scenario that we had provided for you last time. And so we'll talk through the answer, and then we'll discuss what the May practice scenario will be. And then, of course, we'll provide that answer at our next AHC talk. So for this one, we were looking at, we have a 72-year-old female who was referred to home health for medication, education, and physical therapy for strengthening related to a recent hospitalization for exacerbation of the COPD. The patient also has confirmed documented asthma and emphysema, as well as coronary artery disease with chest pain. And then the patient also has mitral and aortic valve disease, but that aortic valve has been replaced. So tried to provide some information here to help us really think through some of these scenarios, as we know it's not always black and white. Okay, so here's how we would code this. Now, J44-1, really the patient was hospitalized for the exacerbation of the COPD, and this is what we listed as primary. Because of that exacerbation and hospitalization, asthma is not added as the type is not known, nor is asthma exacerbated. Remember, our guidance tells us that what we really need to do is that if you don't know the type of asthma specifically, or it's not exacerbated, then we're not going to add that as an additional code. And because we have a type of COPD, not just COPD with asthma, we're not going to use that J4489. I know these are all over the place and it can get very confusing. I think I have to look them up every single time. But when you look at the alpha index for a patient with asthma with an exacerbation, it's going to lead you to that J44.1. Now, the guidance also, or the coding tips also tell us it, and there's no excludes one, that emphysema unspecified is going to be added when it's confirmed, as long as a type of COPD is listed. Now, exacerbation of COPD is considered a type of COPD. Now, if all we had was COPD and it wasn't exacerbated, and we didn't have a specific type, then we would use just the emphysema. So I hope that's not too confusing for people. And again, if you have questions, you can reach out to Jan and we'll follow back up offline for that. Now, CAD is coded, and I bet you're wondering, okay, well, the patient has chest pain. Why didn't we add the code with angina? And just to make sure you understand, the record must actually say angina and not just chest pain in order to use a CAD code that includes that angina pectoris. And then the last two codes we're going to add is the rheumatic mitral valve disease, IO5, unspecified, because the mitral valve disease is continuing, but the aortic valve disease is considered resolved with that valve replacement. And then, of course, we're going to use as best practice the Z95-2 to capture the presence of prosthetic heart valve on that coding scenario as well.
Great.
All
Thanks,
right,
Nanette.
so for May, so for May, we have some OASIS scenarios. I'm not going to read that to you, but you will have this PowerPoint downloaded, and then feel free to look at that, and then we'll cover that at the next AHC Talk.
Fantastic. And these slides for this call will be up on the AHC website after the call, so you can download them and take a look at this scenario and try your hand at the responses before our next call. Fantastic. Thanks again, ladies. And I'm just going to move into our last couple of segments here. We have the product spotlight, and we want to let you know about Decision Health's 2025 Home Health Payment and Compliance Virtual Summit, which is happening on September 9 through 10. And Apryl will be speaking, and so will several other AHC board members and members of the AHC committees. So we hope you'll join us there. In just 2 afternoons, you'll gain expert insights and actionable strategies to help your agency succeed. The speakers will be covering the latest changes to coding, OASIS, value-based purchasing, medical review, survey preparedness, and more. So just follow that link in the handouts for more information and to register. And it's also time for What's New with AHC, where we share updates from the Association of Home Care, Coding, and Compliance. And I just wanted to let you know, if you're an AHC member, we just had a great members webinar where we discussed value-based purchasing, more about the OASIS GG items, and we shared recent coding and OASIS updates. And the recording of that webinar is on the AHC website under resources and then the webinars. And if you're not an AHC member yet, please join us. We've included a link in the handouts so that you can learn more and join, and you'd be able to access that webinar once you're a member. And if you're listening to a podcast version of this show, you'll find the handouts on the AHC website along with the recording under resources and free webinars. We hope you enjoyed this episode of AHC Talk. Thanks again to Apryl and Nanette for all the great information, and thanks to all of you for tuning in. We hope you'll join us again for our June call. In the meantime, if you'd like to re-listen to this episode or to a previous one on the go, you can find AHC Talk on your favorite podcast app. Or you can also listen to the recording and access the handouts on the AHC website at ahc.decisionhealth.com. And if any of you have suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening. Thanks again to our panelists, and we'll see you again next month. Take care.